the GI Hepatology Echo of Sub-Saharan Africa. And the theme of this afternoon is choosing wisely, and it's specifically about iatrogenic anemia. So G-ECHO is hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. And these sessions are held every Wednesday at this time. And today we're really excited because we've got participants from no less than 12 countries, including the Cameroon, Ethiopia, Ghana, Kenya, Mozambique, Namibia, Sudan, Tanzania, Zambia, Zimbabwe, and even South Africa. So what a wonderful bunch. And so far we've got 52 people registered and from quite a diverse number of backgrounds, mainly people obviously from gastroenterology background, gastroenterologists, hepatologists, but also general practitioners, general surgeons, and oncologists, hematologists, and then obviously physicians and some pathologists as well, not to mention people from the pharmaceutical industry. So thank you so much for your attendance. Just as a general housekeeping rule, I'd like to ask that you make sure that your microphones are muted when you are not speaking so that we can give our speakers time to talk. I'd also like to encourage you to engage with the speakers actively in the discussion platform, which we'll have later on. And you can also use the chat function if you want to post a question, specifically if your microphone is not working or you don't want to necessarily speak out your chat. But note that we're only going to respond to questions at the end of the session. And yes, I'd like to really just introduce this session by saying that yesterday was a big day for patient blood management internationally. The World Health Organization launched a policy brief, and it was called the Urgent Need to Implement PBM. And this brief was really just to create awareness of patient blood management and to create a sense of urgency in all health entities around the world to implement patient blood management. They had a couple of other purposes, but the biggest one was to act as an accelerant for change. And I must say, this really was, has had the effect already. And today I was approached by one of our smaller hospitals in Bethlehem in the Eastern Free State and asked, won't I go and hold a workshop there? They've already got 56 people that they want to attend. So it really seems to, in one day, already have done something in the little Free State. So a reminder that the goal of PBM is not to only reduce blood transfusion or restrict the use of transfusion, but to try and remove away from this default that transfusion is the default treatment for anybody with anemia. So Prof Coetzee is going to talk to us more about specifically iatrogenic anemia and how we can look at reducing the numbers of transfusion by implementing effective minimal blood loss. So to introduce Prof Coetzee, he is a longtime colleague of mine. He's a retired hematopathologist, a registered clinical hematologist, and he's got a passion for many things, but for bleeding disorders, specifically hemophilia. He's passionate about patient blood management and is an incredible ethicist. He's actively involved at the moment with developing a curriculum for a short learning program, for patient blood management for doctors, with a very South African and African theme and feel, which should be ready for enrollment in the middle of next year. So he is the man of the moment now, and I'd like to introduce Prof Coetzee.
Good afternoon, everyone. Is my slide visible?
Yes, it is, Prof.
All right, thanks. There's been a Choosing Wisely campaign, especially in the Northern Hemisphere, about only doing things for which there is proof. And I'm combining that with patient blood management and especially iatrogenic anemia. Now, one of the most catchy titles, one of the publications was by Marcel Levy in 2014, and he calculated that about 25 million liters of human blood lands in the sewers in Europe, and that is blood that's been actually drawn for diagnostic purposes. I'm going to kick off by just repeating the policy brief issued by the WHO. It's freely available on their website, very easy to read, and encompasses even today's talk. Okay, so according to the IFPBM, a definition of patient blood management is an evidence-based bundle of care to optimize medical and surgical patient outcomes by clinically managing and preserving a patient's blood. Now, here we have the three pillars. Firstly, building up the patient's blood. The second one is then minimizing blood loss and bleeding. And this is the one that I'm going to focus on this afternoon. So this is from one of my favorite TV series, the Naval Crime Scene Investigators. And this Jethro Gibbs, sorry, always says, don't take anything for granted. If your mother says she's your mother, don't believe her, almost. And this is the sort of attitude one has to have when trying to promote patient blood management. Okay, so here are some of the definitions from Whitehead, who had a systematic review in 2019. Iatrogenic anemia is the development of anemia due to medical procedures and is of universal concern in critically ill patients. The wider concept is any anemia caused by medical interventions like surgery. And then the current handy one is this anemia resulting from blood being drawn from a patient or diagnostic blood loss. That's the one we're concentrating on. It's even been called the anemia of chronic investigation. And there's also the concept of hospital-acquired anemia, but that involves surgery and complications, including diagnostic blood loss. All right. So here's a schematic. Here we have the patient's blood, then the doctor decides to diagnose the patient or monitor the patient's progress. Then blood is drawn, and in the ICU, some of it is returned to the patient. If not all the blood that's drawn is put into the specimen tube, if drawn with a syringe, the blood also goes to medical waste. Then you have the blood in the specimen tube. You can vary the size of the specimen tube. If the blood was drawn incorrectly or into the wrong tube, we have a pre-analytical error, and the blood also goes to medical waste. Just to emphasize that 70% of laboratory errors occur before the blood actually reaches the laboratory. So it's actually important for people who know what they do to draw the blood. Then blood is used for analysis. The less blood, the better. And usually the excess is stored for a few days in a fridge in case there are add-on questions. And here we have the Choosing Wisely emblem of the Choosing Wisely campaign. Okay, just some history. In 1866, Hughes Bennett in Edinburgh found that patients do better without bloodletting, because it was standard practice to do bloodletting if patients get admitted with pneumonia. In 78, Rosenzweig and colleagues noted that a full blood count taking 7 milliliters per day actually resulted in over 200 milliliters of blood loss per month. This was followed up later. And then here we have Henry in 1986, 377 milliliters of diagnostic blood for a stay in intensive care, or 240 in a surgical ICU. Here, Dale et al. From the Mayo Clinic in 93, labs draw about 45 times the required volume of specimen that they need. And patients receiving transfusions were in ICU usually had 60 to 70 milliliters of blood drawn per day. And they found that phlebotomy or diagnostic blood loss accounts for about half of the variation in the number of red cell units transfused in ICU. Okay, let's concentrate on anemia in the ICU. So here are some quotations. The hemoglobin concentrations typically decline by 0.5 gram per deciliter per day during the first days of in the intensive care unit in a non-bleeding patient. Almost 30% of the blood taken is discarded, Holland et al. And then this important publication by Koch et al. About bloodletting in the cardiac surgical unit, published in 2015. They showed that the total diagnostic blood loss during a cardiac ICU stay is equivalent to 1 or 2 units of red cells. And then this often triggered a blood transfusion. Leon et al. Made this summary, or almost a systematic review, and they showed that from about 7 publications from 73 to about 2009, the average blood loss was 53.2 milliliters per day in an ICU. Of course, there was quite a lot of variation. And they tried to model it, and it just showed that if a patient was not bleeding, their HB usually declined with the ICU stay and days of phlebotomy. If they were bleeding, it happened quicker, and if the patients had no marrow response, it even happened more quickly. So what are the causes of anemia in an ICU patient? Well, firstly, ICU patients are often admitted with anemia. There is associated surgery, there's bleeding, and then there's also anemia of chronic disorders, the effect of inflammation, decreased renal function, suppressed hematopoiesis, and also, paradoxically, the effect that anemic patients are often worked up more aggressively. This is a nice summary that was published in 2012. And I'm certain there are other things that the audience can also think of. All right, so when you draw blood from patients in ICU, there's heparin and so forth in the lines. So one has to withdraw the heparin first and then take the specimen. So there are various devices where, for instance, you draw the blood into a syringe and then return it, or there are also circular syringes. So here are some two publications that actually emphasize that non-pharmacological interventions that can reduce red cell transfusion are needed. At the moment, I don't think these devices are really standard, and there have been problems with some of the devices that have been introduced in the past. Okay, let's just think about diagnostic blood loss. So do we collect too much blood? Do labs collect too much blood? Here's a study from 2003 by Dan and Ruby saying that we collect about 8.5 times more than is needed for a full blood count, or 12 times the blood that is usually needed for the analysis of electrolytes. And you know, the larger the tube into which the blood is drawn, the more blood is discarded. These authors in 2005 found that on an average, for every 100 milliliters of phlebotomy, you had a decrease in the hemoglobin and the hematocrit by 0.7 grams per deciliter. A chart, excuse my dogs. So a chart in 2006 showed that even small increases in the average volume of phlebotomy, 3.5 milliliters per day, were associated with a doubling in the odds of having a transfusion within 21 days. Salisbury studied a diagnostic blood loss for patients who were admitted with myocardial infarctions. And you can see here that actually whether you were admitted with a mild anemia and or even a severe anemia, the amount the HB dropped over the 10 days of admission. So how much blood do we actually need for a full blood count? So here's a publication in the International Journal of Lab Hematology in 2010, where a lot of blood was drawn and then split into small aliquots. And it showed that 1 milliliter of blood usually gave a very good result for platelets and white cells, apart from the hemoglobin. And that is because, you know, when the blood is drawn into the analytical instrument, it has to fill the tube that leads up to the place where the analysis is done, and then you still use a bit of blood. The other thing is that the tip from that actually points into the blood needs to be fairly deep under the surface, not to suck up air. So, and then, of course, in between every sample, the instrument is washed. So you have this kind of dead volume, even though one uses about a tenth of that volume for the analysis, you actually need more blood. And then here's a publication later on in 2016 to show that the underfilling of normal tubes does not influence full blood count results. Of course, if it goes below 1 milliliter, you've got a problem. All right, so now we get to smaller tubes. Well, the obvious thing is to use pediatric tubes. But remember that in pediatrics, blood is drawn with a syringe, and then the blood is put in the tube. These are small tubes and have to be handled manually. They don't go into the racks in laboratories. So, for instance, what BD has got is the micro container tube adapted for laboratories, and it has the normal pediatric tube with a hollow extension, so that this tube is actually as long as the normal tube. But this is only available for EDTA. That is the tube we use for full blood counts and DNA especially. The alternative are the partial draw tubes. So usually, this is a 4 milliliter kind of tube. The blood is drawn up to there, but because there's less vacuum, the blood is only drawn up to there. So you only, for instance, draw 2 milliliters. This is actually handy because it not only draws less blood, but the proportion of blood to EDTA is then smaller, and the chances of getting a clot are less. Also, because there's less vacuum, there's less hemolysis, and hemolyzed blood interferes with analysis of lots of things like electrolytes. So I contacted Claire Marcus of BD, and she confirmed that there are actually 45 sites in South Africa, split between the public, private, and academic sites that use the MAP tube. This is the pediatric tube with the hollow extension. And there are a few sites that actually use the partial draw. If you have ever drawn blood in a clinical trial, you might have been confused that the clinical trials especially use these partial draw tubes to limit the amount of blood that they collect per study. This is Wu et al. From the Mayo Clinic proceedings of this year, show that they introduced smaller tubes. They didn't say what type, but the thing is, you can see here that the amount of blood drawn for coagulation really dropped compared to before, during, and then after the intervention or the campaign they had. This is repeated for various other things. But the most encouraging graph is here at the bottom left. And this shows that, for instance, in the hospital, that the mean hemoglobin level of the patients actually increased during the course of the campaign. So it really does help to use smaller tubes. So can one use smaller tubes in all settings? Miles et al. In Australia published the use of small volume tubes for iatrogenic blood loss in a cohort of adult hematology patients. Now, in hematology, a lot of blood is drawn. And it's just interesting that one of the authors is a von Willich, who's probably a South African expatriate. In any case, they used partial draw tubes, and they showed that you got a 42% reduction in the blood volume that was lost. At Universitas Hospital in the hematology outpatients, we managed to convince the NHLS to provide us with 2 milliliter partial draw tubes for full blood counts. And this seems to be working very well over the past year or so. Okay, so what? Let's break out of this box and see if we can't measure hemoglobin without drawing blood. There's been quite a lot of progress with this. For instance, one can fairly easily measure bilirubin concentrations in babies in this way. But the thing is, at this stage, the technology isn't that good. You have to then shine a light, through a blood vessel and actually get an impression of what the hemoglobin is. But I'm certain this will become available in an improved version pretty soon. And if not for doing a diagnosis, for making a diagnosis, at least it can monitor a patient's HD in ICU or in hospital. All right, so what can we actually do in general to reduce diagnostic blood loss? There was a very good systematic review by Whitehead et al. In 2019, and they suggested that we look at non-invasive testing, for instance, these something like sorry, I just can't think of the right word, but at least you can put something on a guy's finger and you can get a good idea of the hemoglobin. Then blood conservation devices and techniques where the blood contaminated with heparin in the ICU is returned, point of care testing, education, and then decisions support tools for everybody who decides to draw blood. Okay, these were the conclusions of that systematic review. There's a need for devices that return blood for testing or flushing. There need to be blood conservation systems for arterial and venous catheters, and then also small tubes. All right. So why not move out of the lab completely? I'm certain this will happen over the next few years, increasingly. The American Association for Clinical Chemistry published a guidance document on point-of-care testing in 2020. And they tried to discuss 7 questions. The first one is, what is the value of an interdisciplinary committee to oversee point-of-care testing? So that means, the clinical team, the lab team, etc. Does education improve point-of-care performance? It seems definitely so. If people are trained to use the point-of-care instruments correctly, the results become more and more repeatable. What's the optimal staffing model for point-of-care testing? Should one have people who do it specifically or not? Or do you need an extra nurse in the ward? Then about proficiency testing or external quality assurance. Does this actually improve things? And actually, if one has some form of external quality assurance where calibrated specimens are sent to a lot of hospitals as to check that their results are correct, it does actually improve the system. Does data management improve point-of-care testing? The important thing is that if you do something like a urine dipstick, it is the person who does it who has to write down the information in the notes. Ideally, point-of-care instruments should be linked through the internet to the hospital information system or lab so that the results can become part of a person's permanent records. The second last question was, which staff should select the point-of-care devices? And the WHO has also got good advice about that. And actually, does implementing point-of-care testing improve the patient management process? All right. So I'm just thinking of two situations here. For testing anemia, there is the WHO color scale, but that needs special kind of filter paper for testing it against the color scale. And it can only measure down to hemoglobin of about 9. The Hemacue devices, and I've got a small picture of one of the models there, have been thoroughly tested. So you have a little cuvette where you make a prick in the patient's blood. The blood is collected in the cuvette and you push the cuvette in here. The results are very reliable, and you can actually connect these instruments to and back up their data. Then when we get to the viscoelastic tests like the Rotem and the TG, for instance, the newer cartridge versions are easier to manage. They're ideal for perioperative management. They're useful for establishing a trend, during the operation or patient stay. But unfortunately, there is no quality assurance connected to these. And they are not so useful in making diagnoses of bleeding disorders. All right, so now we are going to go back to the people who make the decision whether the blood should be drawn or not. The Society for the Advancement of Patient Blood Management has got 5 directives, but one of them here that is pertinent today is don't perform laboratory testing unless clinically indicated or necessary for a diagnosis or management in order to avoid iatrogenic anemia. So one should identify what questions you need to answer, and you should go through this process before you draw the blood, and you should draw the least amount of blood. So, it's difficult to make a decision about what sort of blood needs to be drawn. You need, if you draw more blood, you can probably get more answers per 24 hours and get the patient out of the hospital quicker. But there is some kind of middle ground. Similarly, the American Association of Blood Banks in 2014 said don't perform serial blood counts on clinically stable patients. And the Critical Care Society's Collaborative in 2014 says don't order diagnostic tests at regular intervals, such as every day, but rather in response to clinical questions. Now, so let's try and summarize what we've talked about. Here we have the patient's blood. There we have the doctor choosing wisely. We can, by improving the way blood is drawn in ICUs, we can actually return some of the blood to the patient. Instead of drawing tubes of blood, we can do point-of-care testing. We shouldn't draw too much blood, otherwise it goes to medical waste. Smaller tubes are already something where I'm certain the price will drop as more people use it. We should decide which tubes to draw correctly, and the labs can even get by with less blood. So I just want to say that let us practice medicine that is patient-centered and not defensive. So we don't draw liters of blood just to cover our backsides in case of litigation. And let's practice evidence-based, not eminence-based medicine. Thank you very much.
Okay, thank you so much, Prof Coetzee, for a wonderful presentation and for giving us an absolute tour of iatrogenic anemia, or anemia of chronic investigation, which I'm going to call it from now on. I really want to commend you also on doing a small, big thing by introducing small volume partial draw tubes at the hematology clinic. And I think that one should never look at these small, big things as small things. They're actually big things, and hopefully can change practice in the larger hospital setting and hopefully make a big difference to patients. I'm not going to discuss anything now, and we're also not going to open up for questions quite yet. I'd now like to introduce one of the students at the University of the Free State, JC Adams. He is a final year surgery registrar who is passionate about patient blood management. About 3 years ago, I did a presentation at the critical care and presented ICU, anemia in ICU and how it relates to patient blood management. And JC cornered me and wouldn't let me escape the room and said that's what he wants to do his MEd project on. And yeah, so he's going to share with us the results of his study. And yeah, JC, thank you so much for being willing to do this. I know you're busy grinding and getting ready for exams. So you can maybe just to start sharing your slides, JC, so that we can see that you on. And there we go. Okay, thank you so much, JC. Just unmute yourself, JC.
My apologies. Thank you for the introduction, Claire. Yeah, so my MEd is looking at very similar, or what Prof actually mentioned, was looking at iatrogenic blood loss in critical care, which is a single center experience at our tertiary academic hospital at Universitas Central Free State. So a lot, Prof probably talked a lot about what I kind of wanted to rehash, but I think it's important to actually talk about what we have found at our local data and at our center. So I've got no conflicts or interest to declare. So I'm not sure if everybody knows about Elizabeth Holmes. She created an $11 billion company called Theranos recently, well, in 2007 to 2016. And she had this amazing idea to actually, as we were thinking of small volumes, to use that for blood test or for testing for investigations for patients. And from this small amount, using nanotechnology, you can actually do 1,000 types of tests. And this was amazing for the world out there, especially for the scientific and clinical world or clinical fraternity, that we actually have something where we can actually minimize blood loss in a patient. And what she said was that she's going to use this 1.29 centimeter nanotube to actually do all these, to have capability of doing all these automated laboratory tests. Unfortunately, there was no accurate science in this. It was based on a lot of fraudulent hypotheses, and unfortunately, she actually succumbed to this. Well, fortunately, because she lied to the world. But the idea of what she wanted was actually an amazing idea, and this is what we actually should be striving for, specifically for laboratory sciences. So to introduce what I've done for my MEd is that just a bit of history or of information regarding the literature. We know that there's many studies, as Prof also actually mentioned, is that there's a high prevalence of hospital-acquired anemia. And it has a lot of effects in terms of the patient that gets admitted to ICU. And most of our patients admitted to ICU are already patients that are anemic, and they already have severely suppressed hematological function. And now we're actually just worsening this. And this has been evident by many studies, as Prof also mentioned, and other studies. There's a host of them that actually confirms all of these findings. One important local study that we actually did currently or recently in 2018, which was the SASO study, which Masakano actually showed that in South Africa, 47.8% of our patients actually have anemia, specifically preoperative patients. And this is a big amount of patients that are actually in a poor condition, because we know with anemia, there's a lot of other underlying associated factors that actually contributes to all of this. And with multiple studies also, and multi-center studies actually confirms that anemia is associated with a lot of increased morbidity and mortality. It has, especially in patients in the ICU, it has increased with long-term stay in ICU. It has an increased risk of patients being staying on a ventilator for much longer than anticipated. My apologies. And we need to demand some form of change in our transfusion practices, and there should be some form of paradigm shift in the way we actually start doing things. And that's where the society, my apologies, the Society for the Advancement of Blood Management, actually their definition of this is that there's a timely application of evidence-based medical and surgical concepts designed to firstly maintain HB concentrations, to optimize hemostasis and minimize blood loss to improve patient outcomes. As you can see in the corner, there is a diagram that actually with 4 spheres where you actually need to improve patient outcomes. And all of these spheres actually will assist in helping you improve patient outcomes. And a lot of the PMB or patient blood management principle, one of the principles is that you need to make sure that everything is based on being patient-centered, and the decision-making is according to being patient-centered. And we're not treating the disease alone, but we're actually treating the patient. And there's a lot of these things that we need to optimize in terms of coagulation, as Prof mentioned, blood conservation, other types of modalities, and then we have to obviously manage this anemia. So moving forward, PBM has these 3 principles. Prof also has mentioned that, but importantly for us in my study, or what we've done, is that we were looking at the second pillar, where it's actually minimizing blood loss and bleeding. And if you look at all 3 tiers, which is pre-op, intra-op, and post-op, in the second pillar and third pillar, there is always a way or a means of actually minimizing iatrogenic blood loss. And even post-operative, you need to do that pre-operatively, and in the third pillar after, to enhance patients or optimize the patient's physiological reserve of anemia, you actually need to try to limit the amount of blood that's actually lost, or the amount of blood that you're actually taking. So the aim of the MED was looking at iatrogenic anemia and how it actually has a contribution to patients in ICU. What is the importance of our local data? Because we need to establish some form of baseline info or data to actually implement all of these principles for patient blood management. And what we looked at our institution at Universitas Academic Hospital, situated in South Africa, Bloemfontein, we looked at the number of collection tubes that was actually used, the type of laboratory tests that was actually requested, but importantly, is looking at the daily amount of blood that was actually submitted for testing, and actually looking at what was the excess of what we actually required. Moving on, in terms of the materials and methods, it's a descriptive prospective observational study done at Universitas Academic Hospital. We involved all ICUs, which is a 5-unit ICU, total of 32 beds, which is made up of specific specialty ICUs with 1 multidisciplinary unit, which actually admits all types of patients from all specialties in the hospital. The study was done over a period of 14 days, from the 7th till the 20th, and all of these patients actually had informed consent and ethics approval from the HSREC Committee for Ethics. So looking at looking at some of the results, my apologies, I just need to go back quickly. Okay, so with materials and methods, and how did we actually look at, how did we measure this blood volumes? And we actually we figured out a novel way of actually calculating blood volumes without actually using a syringe. So what we did was we actually weighed the average blood, average weight of each PD-vac container tube. We specifically looked at specific sizes. We used, and because we knew what the density of blood is, which was done by a study in 1974, which actually looked at the density of blood at various temperatures, 4 degrees and 37 degrees, it actually stayed constant at 1.606 grams per mole. And we actually just with a mathematical calculation, we actually interpret and could calculate and convert the weight into milliliters. And that's how we actually, without having to actually take the blood from the patient, myself as the researcher. These tests were done during 4 till 6 o'clock in the morning for every day for 2 weeks, as this was the routine times for ICU testing. To note, there is limitations of the study. There was underestimation of blood volumes drawn. Unfortunately, some blood specimens were discarded, especially taking from arterial lines. There's this amount to prime the line. You actually eventually they will actually discard an amount of that. And arterial blood gases, blood that was taken for transfusions that was sent to the blood bank, blood that was taken for certain pharmacological investigations were actually excluded. In terms of the statistical analysis, which was done by the Department of Biostatistics at the University of the Free State, we reported the data as numerical data with interquartile ranges and categorical data as proportions by means of frequency and percentiles. So just moving on to the results, just basic demographic data. So the median age was about 56 years. Majority of our patients were 30 years, were females. And the median length of ICU stay was about 3 days. And as you can see, majority of our patients were actually post-operative patients, about 50.8% of these patients. As looking at the number of and the type of PD-vac cutaneous that was actually submitted, over the 170 patient days that were calculated, there was 342 tubes that was actually submitted. And of that, the serum separated tube was 169, EDTA 128, with citrate 45. And this actually equates to about 2 tubes that were submitted per day. And for the duration of the ICU admission per day was around 4. So tubes per day was per patient per day. So looking at the laboratory investigations, as you can see in the table, majority of our tests that were actually done were the full blood count, urea and electrolytes with creatinine and CRP. Those were the majority of tests that were actually requested with the minimum and maximum values of these tests. And this was for all patients per day. It was around 1 for the full blood count, 1 for USC, and 1 for CRP. Moving on to what was done over the 14-day period, you can see there's a trend of also for FPC, UEC, and the CRP, which is C-reactive protein, with a max of for your FPC was almost 14 times over a period of the 14 days. So quite high volumes of FPCs that were actually requested. And the daily test median was about 4 tests, and for the duration of the ICU admission was around 7, which with minimums of 3 up to about 16 tests for the ICU admission. In this diagram or figure, which results are plotted against a box and whisker plot, we actually looked at the various types of tubes, citrate tube, EDTA, and SST, and looked at what was actually submitted, what was required, and what was in excess. And if you're looking at the citrate tube, there was 4.3 mils submitted per patient per day, with the EDTA of 3.3 mils, and the serum clot SST tube was 3.6. What was required for the citrate tubes was 4.5 For the EDTA, 0.17 milliliters, very small amounts of what is actually required. And you can see, as highlighted by the red arrow, that actually shows that the required amounts is quite minimal or minuscule. For the SST is 0.55 mils, also very low amounts. And what was in excess for the EDTA tube was 3.16 mils, was quite substantial amount, which was submitted unnecessarily. And for the SST, 3.05. And for the overall for this, over the period of per day was about submitted was 7 mils to a maximum of 8.6. And what was excess, which is the important one, is there was quite an amount of 5 mils, up to almost 24 mils that was in excess of what was actually required. And what was only required was 0.7 mils, which is substantial. Looking at the results over the 14-day admission period for the cohort of patients, there's quite a bit of outliers, as you can see, for this time period. And as I encircled in the red, you can actually see that the required amounts is quite minuscule. It's EDTA and SST, minimal amounts. And then looking at what was submitted was 13.6, and what was in excess was 12.1 over the 14-day period. And with highlighting that most of 56% of our sited tubes were actually underfilled. So they were actually never filled to the proper level for the analytical instrument to actually evaluate the diagnostic test, which equates to that these tests were actually rejected, and patients were actually needed to be, repeat blood tests were actually needed to be done. So more blood taken from the patient, increasing patient discomfort, risk of just contributing to the iatrogenic blood loss, which was already happening over this time period. In terms of what the analyzer actually required for our laboratory, in the diagram, you can actually see that's highlighted in the red, that is for each test that was actually requested, you only need a small amount of sample to actually do these tests. Unfortunately, what is needed, as Prof also mentioned, is that there is a dead volume that needs to prime the analytical instrument to actually undertake the test accurately. And for the serum tubes, you actually only need about 500 microliters in addition to what you need for the test. And if you calculate this, this is all still under 1 milliliter. And that is very important for us to evaluate and see what changes can we do in terms of laboratory setting, of evaluating or changing the type of instrumentation that we have to actually do these tests. Over the 14-day period, we took quite a bit of blood from all these patients in the 59-patient cohort, which equated to 1,241 milliliters over the 14-day period. And what actually was only required was 323 moles. And I did a crude test just to calculate what if we calculate this over 12 months. It equates to about 20,000 liters of blood that was actually probably discarded and not used for patient testing. To continue with just discussing and what I've presented here is that blood loss in this study was substantially much lower compared to other studies. There are certain studies that actually, there was a meta-analysis done with 7,000 patients. Just cannot remember the author, where up to a day, about 213 milliliters of patients were actually, 213 mils of blood were actually taken from patients. And that is quite substantial. The excess volumes was quite a large amount. And then we get a false impression that restrictive blood draws contributes to wastage, and there was no actually restrictive blood draws because tubes were actually underfilled. As one of the studies actually showed that 3.5 mils of additional blood is associated with transfusion after day 21, and that standard tube results in 90% of this volumes being discarded. So we don't need to actually ask for a rainbow of extra tubes, because we know that only 7% of this extra blood request will actually be done. So to conclude, the importance is to actually observe culture for blood conservation. We need to actually employ advancement of patient blood management, encourage local studies, and we need to extend patient blood management principles to the laboratory sciences as well. And importantly, is to create a philosophy that every drop counts. Thank you.
Sure, thank you so much, JC, for sharing your research with us. And I just want to emphasize that these numbers look so small. You know, one might think, well, so what? He collected only 5 mils more than was necessary per day. And does that really equate to anything? And just to remind you of what both Prof Coetzee and JC said, that an excess blood draw of 3.5 mil per day actually doubles the risk of transfusion by day 21. So while these numbers look very small, they really are significant. So thank you, JC, for that. And I really do also believe that this really is a significant underestimation of our blood loss, because we didn't analyze all the blood that is sent for arterial blood gases, other point of care testing, and also blood that was sent to pharmacology in that study period. And what's also really super cool about this study was that this excess blood draw was actually done while the nursing staff were quite aware that we were measuring the blood draws. So it didn't even change their their practices whatsoever. So they also believe that what they're doing is right, even while being observed. So that was, yeah, quite interesting. So I'm going to open up the questions now. If anybody does have a question, please do raise your hand. I see that we are running short on time, but if there are any pressing questions, we can discuss them perhaps now. You can, I see Prof Coetzee has got a question for JC. Talk about being put on the spot, JC. JC, less blood was drawn in your study. Was Universitas trying to save blood already? That's your question to answer, JC.
Thank you, Prof, for the question. It's very difficult to actually say, but I think we already started adopting patient blood management in our ICU, and I think we were quite aware of that. Whatever we take actually has an effect on the patient. I think partly due is that some of the bloods were actually that were drawn were outside of the collection times. For quite a few, there was about 5 patients, and they had quite a significant amount of tests that were actually requested. Unfortunately, they couldn't not be included because of the times. But I think we're actually doing a good job in terms of what Universitas is doing, and we have some data now, some baseline data that actually confirms that we're actually doing a better job than some international studies. The other thing I think is important is that we have quite a high turnover of ICU patients. And most of our patients being post-operative, they only stay there for about 2 to 3 days. Even in the coronary unit, 1 day or post-angiogram. So those patients, they don't actually need a lot of blood investigations. So I think that contributes as well to the minimum amount of blood that was actually taken from our patients. If that would answer you, Prof.
Thank you, JC.
Thank you.
I think the other thing that fascinated me was the underfilling of citrate tubes. And I think that we might even underestimate the amount of blood that is lost by having to repeat the citrate tubes. And actually one of the things that I've noticed people doing is that they instinctively know that one of their tubes, citrate tubes, will be rejected. So they somewhat just draw two, and both of them being underfilled. So often resulting in having to draw a third tube once both of their tests are rejected. And I think that that is possibly an underestimated, you know, it looks like we were sending in less blood than necessary, but actually it was less blood than necessary in a bad way. So yeah, I'm going to then just extend thanks. Seeing I don't see any other questions, I want to remind you that the feedback is very, very important. So please, once you click on that link, that we can collect everybody's feedback, and that, you know, helping the organizers to improve the sessions. I just want to thank both JC and Prof. Oh, sorry, I see Prof. Coetzee's hand is up. Sorry, Prof.
Yes, I just wanted to mention about the citrate tubes. The labs prefer that there's a 1 in 10 dilution of citrate, you know, 1 volume of citrate to 9 volumes of blood to standardize everything. So it's actually been it gives better results if you draw a bit more blood, or actually then decrease the whole amount proportionally in a new tube.
Yeah, noted. Thanks, Prof. So thank you so much to Prof. Coetzee and to JC Adams for their presentations. Thank you for taking time to prepare your presentations. I know academically this is a very tough time of year for everybody. Thank you for that. And we'd also like to thank ECHO from the University of New Mexico and the ECHO India team. Please note that the recordings of this will be available on the Gastro Foundation website. So if you do want to go and check up on any of those references, you're welcome to go and find everything there. And I'd really also like to thank the Gastro Foundation, Cheryl Valentine and Karen Fenton for just being an excellent team and organizing these talks every week. Again, thank you to everybody for attending, because without attendees, this would just be a big fat waste of time. And lastly, to thank the sponsors who make it possible: Takeda, Asino, Amgen, Equity, Aspen, and Adcock Ingram. Really, you make such a difference. Thank you for investing in this and investing in education. Thank you very much. Next week's ECHO session has been advertised, and the theme is hepatocellular carcinoma. And I'm sure that you will all receive an email shortly inviting you to this session. Chris, is there anything that you'd like to close off with?
Oh, thank you very much for excellent chairing. We'll bring you back every week.
Yeah, but thank you so much for everybody. Goodbye then.
Thank you, Marius. Thank you, JC. And thank you, Claire.
Thank you.
Thank you, Prof.
Bye-bye. Thank you, Shirley.